Buenas.
Hello, Luigi. How are you
How are
doing?
you? Thank you so much, Alejandro, for joining us for another episode of the Ibarra Exchange, where we're literally going to talk about TOC, in this case, OCD, in this case, relationship OCD. As you know, myself, PhD in Neuroscience, Luigi Pesce from New York, interviewing Alejandro Ibarra, psychologist, clinical psychologist specialized in OCD and telemedicine from Seville, Spain. How have you been doing this week?
Hi, Luigi. Thank you for having me. Today we're going to talk about ROCD, pure OCD. So,
absolutely. Which
yes.
is a good transition between last week when we spoke about homosexual obsessive compulsive disorder, and a good lead way for next week when we're going to talk about obsessive compulsive disorder, the specialization in pedophilia, which is going to be another hot topic. But let's focus a lot about relationship OCD. There's a lot of data that suggests, they clearly tell you divorce rate went up from 1 out of 4 to 1 out of 3 to now sort of half. There's a lot of reports that show there's a lot of people have been infidels in their relationships. There's a lot of reports that says that there's a lot of insecurity and a lot of fear to take the next step. Not to mention that in the middle of the pandemic, domestic violence and abuse or fights have increased a lot, especially during the months of March and May, at least here in the United States. So what makes relationship OCD so unique in comparison with all other disorders?
First of all, we have to know and we have to understand the topic in ROCD, not just in obsessive compulsive disorder in general, depends on the symptoms. We have to understand how ROCD works in the family, how it works in the loved one, how it works in the partner. So in PSINCO Alejandro Ibarra, in our practice office, with HOCD and ROCD, with pedophile OCD is one of the most common symptoms and subtypes in our practice office every single day. So the first, we have to understand how it works. The ROCD is one of the most common subset or subtype in OCD. So the first symptoms are that attack, or that the person is rumination with that is in the right or wrong relationship, or what if I don't love my partner, or what if I don't love her or him. So I'm in the right or wrong relationship, or what if my partner has a little noise, or a little nose, or a little mouth, or her hair, or what if their ears, or whatever with some defect, or with the personality. What if her or him is not just or much handsome or pretty or good person or bad person. So all the symptoms are in the right or wrong relationship, or between the symptoms attack to the defect of the person. So
Alejandro, where's the pathology though? Where's the pathology? Where's the sickness? Because I could argue that you don't need to have a PhD in neuroscience. That I could argue that we always strive for perfection. That overthinking about your relationship, it's okay. That you always want things to go down perfect. What makes it a pathology? What makes it a condition, a psychological disorder that needs psychotherapy from a clinician?
Yes. Remember, and don't forget that OCD is multifactorial. So ROCD, specific ROCD, it happened in many clients that are very perfectionists. In fact, more controlling, or people that are always controlling their symptoms or their thoughts or whatever that happen around the person. So we see in our practice office that depends of that strictity or control of their personality, and they're definitely discontrol the symptom. So the reality is the symptoms attack to the person, and that is a problem. So I always, I'm a positive person, so I always, I want to show not just the problem, and also how to solve the problem, okay? Not just the symptoms. And the internet and the Google and the videos are showing all the symptoms to hold the word, because maybe 10 or 15 years ago, we didn't know how to ROCD works. In fact, the research are doing by Guy Doro in 2014. It's not just far away in time. So Philipson in United States, in New York City, has have been making many research about ROCD and Bureau around 25 years ago, but it doesn't have to show to the world. We are showing to the world maybe the last 5 or 10 years. So we are opening a door between our practice office to the world, to many clients, hundreds of clients that are suffering in silence in all the world. So that is ROCD is a reality, and it's a misconception between other psychologists that think at this moment that OCD, it doesn't exist, and they confuse the symptoms between GAD to ROCD. No, ROCD exists. ROCD is a subset or is a subtype in OCD. So it's not GAD, it's not depression, it's not PTSD, it's ROCD. It's a relationship. The person or the sufferer has many anxiety or doubt or guilty or many negative emotion to feel all the symptoms to her or his partner. And this is a reality. And how they make a relationship between the person and the loved one, if they are in the right or wrong relationship. So that is the big problem and the main problem in our OCD.
So you're saying that the main symptoms of it as the constant anxiety, the disruptive thoughts, not necessarily compulsions, not necessarily motor behaviors, but the constant obsession of that takes hours of time and that brings a lot of anxiety, what we call a frequency, time, and length of the symptoms of the mental and the ruminations. And you're saying that the research is just being very recent. There was a professor of Israel that actually just 6 years ago, and 2014, and because of the overlapping with other symptoms, with other disorders such as obsessive compulsive personality disorder, not anxiety, and maybe body dysmorphia, overthinking of your body. That's what creates the big confusion and the problem for the community.
Exactly. That is the first step to the recovery. We have to do a right diagnosis, a right how to the psychoeducation, how to manage the symptoms, how to solve the problem, how to implant or how to do the strategies and the skills to solve the problem with ERP, with exposure, with response prevention, everything that we have to do to solve the problem to our client. So as I told you, I was very confused and very misconception that are so around the OCD and with the ROCD. So the people are suffering in silence, and that is the problem.
A big confusion also that occurs is that people think that ROCD happens at the beginning of your marriage, or when the relationship, only in people of their 20s and their 30s, when they think, that's the transition to take the big step and find the love of your life, the man of your dreams, the woman of your dreams. But reality is that relationship OCD can happen even on teenagers and adolescents or college students in that are 18, that have 1 month in the relation. And it can happen also to people in their 60s and their 50s with they're being married for 30, 35 years. This is a clear disorder that starts with their mental and constant rumination and thoughts that can occur at every age of the lifespan.
Absolutely, that's not true. We have clients in our practice office, and we see every single day that they are in a relationship that are beginning or they are starting with a relationship about 2 or 3 months, and they are with ROCD symptoms. It not depends of if you are married or if you are pregnant or you are nothing. Depends on the symptoms that you suffer in that moment, and the rumination that you have, because you are thinking all the time in the same thing. What if I don't love her? What if I don't love him? And what if I'm not in the relationship, right or wrong? And every single day, at many hours a day, 12 or 18 or 20 hours a day, you are thinking in the same topic, in the same way, because your brain is not working very well. So in many patients, in many cases, we have to combine, or with the medical doctor, we have to combine the ERP with medication, because it's necessary. Depends on the severity of the disorder.
So let's touch a little bit on that. You're saying that these ruminations and anxiety, they can take up to 18 hours a day. So pretty much 3/4 of a day. This is not just being insecure about your relationship and talking to your friend for 2 hours about if you are in the right relationship. This is a clinical disorder that requires clinical attention. And before we go on psychotherapy, let's just make the same disclaimer we made on the Spanish session, where we say this is psychoeducation. In videos as this, they are not a replacement for therapy. They're not even a replacement for diagnosis. It's not enough to watch a video to understand it and to self-diagnose, just as it's not the online test, not even in .org or .edu websites that you see, definitely not in the .com, but this doesn't replace neither diagnosis, neither treatment. You still need a one-on-one person interaction to get clinical assessment and to get the diagnosis. And it also is not a replacement by just calling a doctor and just asking, oh, I have these symptoms, 6 out of 10, this is it. But tell us how ERP can actually work in this population.
Yes, as we know, never the videos or internet or the things that we do every Sunday or through our YouTube channel meant the therapy, because it's necessary and it's very important that the client, that the sufferer, go or connect to their doctors or to their psychologist, to a specialist in OCD. That is a very important thing. So about your question, ERP is the gold standard treatment to all the OCD subsets or subtypes. In our OCD, we have to start with, depends on the sufferer and the case, because most of them, they are suffering with the thought, with the length and the intensity of the thought. So the first step with exposure and response prevention is to do a hierarchy to start the treatment with exposure to the thought. Suppose that the sufferer has many thoughts about, one of the most common thoughts are, what if I don't love her or him? So the first step is to do the right ERP with this kind of thoughts. When we control the symptoms that we can, it lasts around 3 to 6 months. That is the first step to the recovery. That is control the symptoms, that the symptoms doesn't go through like grow up. We control the symptoms. After that, we start with exposure imaginary, that is with imagination, around 30 minutes with the eyes closed in the practice office, to do practice with imaginal. Depends of the imaginal, the situation, the defects that the person has. So
you're visualizing
exactly through your mind. So we have to start to control the symptoms that it lasts around 3 and 6 months. And after that, we have to start to reduce the symptoms. And all the process, the whole process to recovery, maybe can last around 12 and 18 months to all the process. But it's not a rule. It's not a rule because it depends of each individual case. So in our experience, we have controlled the symptoms around 3 months, and all the recovery time is around 12 or 18 months. But it's I always say it's not a rule because it depends on in each case.
I see. So let's talk a little bit more about what happens in these relations. At least for what you're seeing, I know there's never like a set rule. It's a lot of variability. There's a lot of heterogeneity between case by case. But when you have a patient that suffers from relationship OCD, from ROCD, are you the first person, you or the practice in PSINCO Alejandro Ibarra of other psychologists that work under your umbrella, are you the first person to know? Do they usually tell their partner before? Are their partners understanding, know, are aware that they are suffering a relationship OCD, that whether they want it or not is sort of focused around them?
Yes, that is a good question, because depends on each case. We have suffered that share their history with her or his partner. Depends on the shame, the guilty, the intensity of the symptoms, and depends on how you feel your partner in your relationship. Depends of many points of many things. So we are develop some skills and some strategies, some to families or loved one that doesn't understand the symptoms, and many others that yes and really understand the symptoms. So if we have a partner that is collaborating with us, perfect. But if don't, we can also help our clients. So that is a very individually decision. It's like medication. We can recommend something, but the last word.
Right. What do you recommend in this case? Because psychologists that focus on marriage counseling or partnership counseling, they always recommend the more communication, the better. Normally, would you is your recommendation as a clinician from what you're seeing that the person that's suffering relationship OCD must tell their partner?
I always recommend that the sufferer choice. They have to choose. They have to choose, and they have to take the decision. They have to take the control to the symptoms and to the situation. If you want to share your story to your partner, perfect. But if you don't want to share and it's your decision, your own decision, that not share, I can help you too. So depends of each case. We have in our practice office a client that doesn't share their stories, and many clients that yes, and they share their stories. Depends on.
And why is that? Why would be a reason for partners that usually don't share their story? Is it guilt?
The first reason is guilt. Is guilt, and is the lack of depends the lack of
understanding of the situation.
Exactly. It
could also be shame as well, right?
Shame, guilt, the most common emotions in this kind of disorder.
And I will imagine if there's a big overlap between obsessive compulsive anxiety disorder and obsessive compulsive personality disorder, especially in relationship OCD, I will imagine that the person doesn't need to tell their partner because they said, I take control of the situation. I know what I'm doing. But now let's talk about the other individual. Let's talk about the other individual in the relationship that doesn't suffer relationship OCD, but is dating, marrying, or living together. Their significant other is the person that suffers the ROCD. Do you see this, for the most part, this occurs as a happy ending? because do they usually like break up? Do they usually like, because the other person might see the situation very, very, you know, general, and see that they might be the focus of the disease. They might be the reason why they're having the condition. So it's better to stay away and try to heal that person, which will create avoidance.
Exactly. We cannot forget that the stimulus and the trigger are with the loved one. So in many relationships that they break the relationship, that is a big mistake, because they are avoidance. They are doing a big compulsions. Remember and don't forget that here in ROCD, the compulsions are mental: avoidance, reassurance seeking, comparing with others, relationship, that the person that was your loved one before this relationship, you are comparing relationship, comparing symptoms, comparing with many others, or with many other parents, or with many other types, or with many other clients that suffer the same the same disorder as you. But that is a big mistake. And my recommendation always is that we have to put together on the person, that the parents, and we have to do the ERP with both, with the person that suffered the symptoms and with the loved one. Depends on each case, but never break the relationship and put it on like apart. No, it's not the best choice. It doesn't work. So always we have to put together. In fact, many clients send to me, and they repeat every single day to me that what is the best way to work. If I go to my mom, to my parents, or to my family, and put it apart, or what? No, you have to keep together, because the trigger is in your own home, because your trigger is your partner. So you have to put everything together, and you have to do the work with her or with him. That is to solve the problem. That is the challenge in ERP.
And just two quick follow-ups regarding this is also common in same-sex relationships, correct? Relationship OCD. And in both same-sex relations or different sex relations, what happens in terms of intimacy and the frequency that the couple has sexual relations during the symptomatology, during the treatment? Does this translate? Does this causes a reduction in the frequency of sexual relations and even the pleasure of sexual relations?
Definitely a tricky question, really a tricky question. Definitely.
I saw we had the time, so yeah.
Yes, definitely. The intimacy and the sexual area is very harmed and very damaged in all the obsessive compulsive disorder that has contact sexual. For example, HOCD, ROCD, POCD, they are most common subtypes that the sexual area is very affected. It's very like dangerous. So ROCD, exactly. So ROCD, all in many cases, the relations, the sexual area is very damaged, because they always, or the person that suffers the symptoms try to avoid the relation, the sexual, the intimacy. So what is the challenge, and what do we have to do as therapists? We have to put into the ERP how to recover the sexuality, and how to, they always say to me, so Alejandro, I have to do twice a week a relation, a sexual relation, or once a week, or how many? You have to do at least once a week, because it's behavioral. It's not cognitive. It's not through your thoughts. You have to do it because it's a depression. You don't have to wait that you are motivated to do the work. No, that is not true. That is a big mistake. You have to do with behavioral, that wake up, and do the work. So in sexual area, it's the same. You have to do until you, little by little, step by step, you are doing into the recovery. That is the process. That is the right process.
Now, just a final question, and we are definitely going to have an episode regarding this, the overlapping between obsessive compulsive anxiety disorder and obsessive compulsive personality disorder. But when you talk about psychotherapy and the cognitive behavioral therapy, and specifically ERP, how much flexibility does a person that also has obsessive compulsive personality disorder let you? Because we're seeing in the United States a big phenomenon of micromanagement patients, that they go to their clinician, psychologist, or doctor of any area, and they tell them their diagnosis and what medication to treat them. It's like, doctor, you know, they consider doctors as no takers. It's very, very small amount of population, but that tends to happen. I completely imagine a person suffering obsessive compulsive anxiety disorder that has or ROCD as well, telling the psychologist how to treat them, be the therapist and telling them, no, this is how we're gonna do the ERP. Does that happen?
Exactly. That is very frequency in our practice office. Every day we have many clients that said to me always, they say to me, Alejandro, today I went to exposure, or today I went to this exposure, and I don't want to exposure to this. So the question always the same. You are not in the control to the therapy, so I have the whole control to the therapy, and we are going to do the ERP to this way today. So there is no choice at this moment. So it's very frequency that they want to take the control in the therapy. So it's very
because
normal.
Of the same condition. Doesn't mean they're bad people or they're diminishing the role of psychologists. They're just the same condition. Is like, I have to be the one in charge.
Exactly, but remember that CBT, the model CBT, is very directive, it's very controlled, and ERP even is very controlled. So it's not depends of the clients. The clients never has to take the control of the therapy. There is a big mistake. But CBT, the model CBT and ACT, for example, is very controlled, and it works because it's very controlled.
This is a definitely topic to keep going, but we are talking about obsessive compulsive disorder specialized in pedophilia next week, both in the Spanish and the English version.
Pedophile next Sunday. It's a very confused and a very common topic in OCD. So I love this.
I totally predict the backlash that we're gonna get throughout this week, just like we got for the homosexual OCD. But it's really important, the psychoeducation, and keep people informing while at the same time telling them it's not a diagnosis or treatment replacement. Thank you so much for another great week. Really appreciate it.
Great. Thank you, Luigi. Thank you for having me, and see you next Sunday. Okay? Have a great week.
See you next Sunday for the Ibarra Exchange next episode.
Sure. Bye-bye. Take care. Bye-bye.